Hello, and welcome to the Postpartum Years podcast. I am your host, Dr. Ellen Kramp, and I am a physical therapist and a pelvic health specialist. With me today is Catherine Halek. She is an internationally board certified lactation consultant extraordinaire, and today we're going to be talking about oversupply. Cat, what is oversupply?
More than enough milk to feed your baby.
Cool.
Yes. So basically, you are pumping or producing more milk than your baby needs to adequately gain weight.
Is this a problem?
Big time. Big time. Most people don't think it's a problem. Whenever I educate about preventing oversupply, people are like, but yeah, I want more, or I want to have like a stash. I want to stop breastfeeding at 6 months and pumping, and I want baby to get from 6 months to a year my milk. And I'm just like, whoa, okay, well, that's a choice. And I can see why you think that the milk's that important, etc. But oversupply causes lots of issues. And in the research, I will give a better answer than just it's more than milk than your baby needs. In the research, and according to the Academy of Breastfeeding Medicine's protocol, it is 40 ounces in 24 hours or more. Most babies need 25 to 35 ounces in 24 hours. So 40 ounces or more, too much milk.
How does that impact the baby?
It can impact the baby in lots of ways. Babies can develop reflux. They can be gassy. Sometimes it can cause something called lactose overload. Oftentimes you're going to hear in podcasts, in books, about hind milk and foremilk imbalance. And I hate that term because that's just not how boobs work. But once we pump breasts and we see breasts and breast milk outside of the body, then we can quantify how liquidy or how fatty the milk is. And oftentimes with oversupply, there's a lot more water content than there is fat. And so that can cause issues with digestion, stooling, lactose overload. That thing I mentioned is very uncommon. I've rarely seen it. I've seen it a handful of times in like the past 14 years. And it's usually green and frothy poops. And like when I'm talking green, I'm talking like almost fluorescent green. All right. And frothy, like foamy. Okay. And explosive and everywhere. All right.
Sounds lovely.
Yeah. So and that's not comfortable for a baby. And the weird thing about those babies is like usually having a lot of poop with a breastfed baby is a sign that they're getting enough to eat. With those babies, that amount of poop, actually those babies sometimes don't gain weight well. So irritability, fussy, reflux, colic behaviors, that can come with oversupply. Also, usually oversupply and a forceful milk ejection reflex travel together. So it's like basically there's nothing and then there's like fire hose, like just shooting into this baby's mouth. And the baby's like, whoa, Nellie, what's going on? And gets like very overwhelmed. Or like, you know, if you put the baby onto the breast and they go, 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 like they're drowning in the milk basically. And oversupply leads to those issues. I have seen somebody have lower milk supply, but still adequate milk supply and a forceful milk ejection reflex. But it's much more prevalent and more common with oversupply.
Yeah, I've seen this a lot of times in the babies that I've treated as well, who, mom's saying the baby's having difficulty latching, and I'm looking at the latch, and when a baby's latching, they're going to suck, they're going to swallow, they're going to breathe. They're going to suck, swallow, breathe, suck, swallow, breathe, and they're like having to come off the breast
to breathe. With milk, like...
Yes, the baby's leaking. There's milk coming out. But the baby's just getting so much it can't coordinate the breathing and the sucking and the swallowing. In those cases where the baby's getting the fire hose, what do you recommend to those moms?
So you'll see through the literature online, various people will recommend pumping right before, that kind of perpetuates the problem. I'm down when I'm triaging somebody over the phone to get to them, and they're having this problem with the forceful milk rejection reflux, and I can tell from like how I'm talking to the person that that's what's going on. I will recommend that in the short term until we can troubleshoot in person, just so that the baby can actually not drown by milk and eat well, and mom can, have some relief and some from the discomfort of it all. And also, babies will either pull off aggressively and sometimes try to take the nipple with them, or sometimes they will clamp down really, really hard, and that will cause like nipple pain and damage. Also, babies, when they're managing too fast a flow, they also hump their tongue back. And sometimes that kind of gets stuck there so that they kind of just do that whether or not the flow is fast or not. And then that causes them to push the nipple into the roof of their mouth, and that causes nipple damage. So that fast flow causes a lot of issues.
And I've also seen it where the baby's guarding.
Yeah.
And the way they're clamping down, the way they're using their tongue
Yes.
ends up causing mastitis in the mom
Yep.
because the baby's blocking off milk ducts
Yep.
to be able, again, breathe, because
Yes.
that's going to win over
Yeah.
food
I-
each time.
Babies will choose to breathe over eat, and we want them to.
Yes. breathing is very important.
It's more important than eating. Eating is also important, and we need to figure out why they're choosing breathing over eating so that they can actually eat well
Yes.
too. But in the meantime, temporarily, if you're having feeding difficulties and your baby's breathing, we're happy.
Yes. Yes. All right. So how does a mom know if she has oversupply?
That's a great question. Leaking isn't necessarily a sign of oversupply, but it often travels with it. So leaking is an independent factor, but like I said, it's kind of like the fast milk ejection reflex. That often travels with oversupply. So having so much milk that you've fed your baby and then the baby's off of your breast and it just continues to flow might be a sign that you have too much milk. And the baby's like milk drunk, like passed out, like in a coma, just withdrawal. And you're like, and it's still dripping or flowing or spraying. You might have, an issue. Also, the main way the oversupply develops is by us doing all of the things to ensure we don't have low milk supply because we're all worried about having low milk supply. People pump. People use a haka to catch milk. Everybody's worried about going back to work. They think they need to start preparing to have their milk supply ready to go back to work on day one. Babies just come out. They're like, I need to pump. I need to make sure that I have plenty of milk. And that fear and that overstimulation, like the feeding frequency, nipple stimulation, and milk removal is too frequent, is extra, and then that causes oversupply to get established. Typically, that's what it is. I have also seen people that have pituitary tumors. So pituitary tumors in non-pregnant people, men, even, or people that aren't in their pregnancy or postpartum journey can cause you to produce milk. And I've seen a correlation with oversupply and people that have a history of a pituitary tumor. And usually pituitary tumors are benign and usually nothing's done about them. But if you know that you have one and then you decide to get pregnant and have a baby, you might lean towards oversupply.
We've gone over how it happens. How can it be fixed?
Less nipple stimulation, less milk removal, less frequently.
So those moms that are trying to feed the freezer.
Yes. Need to stop. Because eventually we got to stop. And here's the problem, though, is that there's going to be discomfort involved. Breastfeeding and pumping should not hurt. It shouldn't hurt. It shouldn't hurt. But when you have oversupply, having some breast tenderness or discomfort while you're managing it is necessary oftentimes. And oftentimes there is discomfort. And so something called block feeding is recommended. and it may be recommended various and sundry ways. I highly recommend not Googling block feeding if you're currently suffering with oversupply and doing it yourself without guidance, because you need to know when you can stop. So, like, it's important to have guidance and have somebody like weighing the baby, having a weighted feed, seeing the baby's weight gain over time to be like, okay, you can stop the block feeding right now. So, what block feeding is basically you feed off of one breast for a set amount of time and then you don't do anything to the other side. You leave the other side alone, which then gets engorged, painful, and uncomfortable. Oftentimes, also, when you switch sides after that period of time, especially in the first few days of block feeding, the baby has a very hard time latching to the breast.
Because it's a bowling ball they're trying to latch to.
Exactly. It's really hard to latch to a bowling ball, right? The nipple and the nipples will like retract and become flat with engorgement. And so it's just hard to get that going. I would recommend reverse pressure softening on the other side, which is basically pushing some of the edema, the swelling away from the base of the nipple. Yeah. And or hand expression, not pumping, maybe in certain situations, I will recommend pumping. I often create block feeding plans and then schedule very frequent follow-up. I don't give a block feeding plan and then not have a scheduled follow-up session, because block feeding can lead to low milk supply because what?
Less stimulation,
Less nipple
frequency.
Yeah, less milk removal, less nipple stimulation, less frequently, low milk supply, right? So we want to know when we can stop and go back to some kind of a normal or stay where we are. Oftentimes, moms with oversupply are already noticing that their baby can only handle one breast per feed. Like, that's very common. And so they're already kind of doing a version of block feeding. Unfortunately, what I also see them doing is pumping or using the haka because of the discomfort. Like, they don't want to have the discomfort. They can't mediate that feeling, and it's just too much for them. And so a lot of my counseling for oversupply is talking about, like, okay, get ready for the discomfort, use ice, use ibuprofen, Tylenol, anti-inflammatories. In extreme cases, where we have tried all of our conservative measures to tamp down that milk supply, and it is still just not, it's not good enough. Doctors and or sometimes lactation consultants will recommend pseudoephedrine, because pseudoephedrine is like it can dry up your milk, but in higher doses than you would take for like a sinus infection or a cold. So like usually it's recommended like 60 to 120 milligrams of pseudoephedrine. That I don't necessarily recommend very often. I would want a doctor to recommend it because it's a medication, and that's not in my scope of practice to say that. And there's also risk factors with pseudoephedrine. I have like weird bladder problems when I take Sudafed too much. So, it's not without risks.
And there are the occasional women who have like extremely high prolactin levels.
Yes.
That just produce copious amounts
Yes.
of milk. Now that's probably going to need to be handled with a physician.
Yeah.
Because of
well, and
the
the pituitary gland tumor is a part of why that produces milk, is because it increases the prolactin levels. So those things go hand in hand. Herbal remedies are like few and far between. A lot of my dietats that I've worked with in the past, they prefer herbs over medications. And there is zero research that supports this. But in my clinical experience, sometimes I have them brew about 32 ounces of extra strong peppermint tea and drink that in a day, and with block feeding. And so it's like, who knows exactly what's working, but sometimes it helps speed up the block feeding process. Another herb that's recommended to help dry up milk or to manage oversupply is sage. I find it a lot easier to find peppermint tea than to find sage tea.
If you're going to summarize what to do as far as oversupply, how would you summarize that?
You need frequent follow-up. You need help. You need guidance. A DIY is dangerous. It can cause things to get too bad in one direction. Also, you're at an increase when you're block feeding, you're at an increased risk for mastitis and plugged ducts. And so, not being in the care of somebody that's helping you manage that process is dangerous and can cause more side effects and more issues and can cause your baby to stop gaining weight. Or there's, yeah, like really oversupply lends itself to needing help. I would not recommend doing it yourself. One time, a client of mine had come to me and she researched oversupply, knew that that was the problem. She was right, she was correct. But the recommendation that she read somewhere was to breastfeed on one breast for 12 hours. We usually start with 4, sometimes as little as 2, depending on what the mom has previously been doing. Sometimes we just start with don't pump in addition to breastfeeding. Don't use the haka in addition to breastfeeding. But imagine you had like slightly oversupply and you just only offered one breast for 12 hours. Nobody's telling you what to do with the other side. Nobody's telling you to use ice, ibuprofen, Tylenol, anti-inflammatories, maybe do some reverse pressure softening, like that could be disastrous. It could cause mastitis. That could turn into something severe, like infectious mastitis can turn into sepsis. It can turn into abscesses. And it's just like, no, like I wish I could scour the internet and remove that because, or be like, this is what I did after I tried all of these other things and then this worked, like in context. Yeah. But really oversupply needs help and support to get over it. And we want to monitor the mom's breasts and the baby and the weight gain and the milk supply closely. And we want frequent follow-up. A pet peeve of mine with some IBCLCs, because we feel bad for scheduling follow-up because insurance might not pay for it, or we're asking these families to pay out of pocket, is they don't schedule enough follow-up. And so they give care plans and then they're like, see you in a month. And I'm like, I want to see this person in like 3 days. Like, so I know so people can stop doing the crazy things faster.
Is there anything else you want to add to the topic of oversupply?
You can focus on breastfeeding at the breast for the first 2 weeks. Focus on that. If you have a 3-month, if you don't have to go back to work for 3 months, you have time to just focus on breastfeeding for at least the first 2 weeks. You don't need a pump unless somebody tells you to, because baby's not transferring. There's reasons why you should pump, okay, in that first 2 weeks. But most people that have healthy anatomy and healthy systems and don't have hormonal issues or signs of low milk supply can just focus on breastfeeding and get in sync with your baby. And that being in sync with your baby is one of the miracles that is direct breastfeeding or chest feeding, is that when your baby needs to come to the breast, because your breast will be like, hey, it's time. And you grab the baby and the baby's not even crying or fussy or cooing, and you put the baby on, the baby eats, the baby's happy, you're happy. It's so, like, I was lucky enough to experience that, being in sync with my baby. And it's one of the most beautiful things. When we introduce bottles too early, when we introduce pumping too early, when we introduce hakas, which are like silicone milk collectors with suction, those things interfere with you being in sync with your baby. And I wish everybody could have that experience if they choose to. Then you can introduce pumping closer to your start date. You don't need a stash. You don't need to have hundreds and hundreds and hundreds and hundreds of ounces of milk. You don't need a deep freezer. I have a client that just bought her second deep freezer. Yeah. And I'm just like, she told me that was just this week. And I was just like, you bought another one? Okay. All right, cool. We need to figure this out. Because, like, are you going to buy a third? Like, how many deep freezers how big is your garage? What is going on here? Like, and y'all got deep freezer money like that? So, but I think that just understanding, and there's exceptions to this. Like I've worked with a lot of medical professionals. I've worked with people in nursing school, doctors that are in residency, and they're going to be going back to work at 6 weeks. And I'm like, I don't tell them to just enjoy breastfeeding the first 2 weeks. I'm like, yeah, go ahead and start pumping. You got 6 weeks of leave, that's that, and unpaid, and this is all you're going to get. Or I've had nursing students who literally they were going to have to restart everything or like be a year and a half delayed because they couldn't finish this last clinical rotation. And I was once called to help support a mom who was going back to her nursing clinical rotations on Monday. It was Saturday. She had the baby on Thursday. So there,
Yay, America.
yeah. Yay, not understanding that people have babies while they're in school. Like, and we should make special accommodations for those circumstances because it's going to happen and it does happen all the time. So there's my rule of thumb for like when to start pumping is kind of like at the 1/3 mark of your maternity leave is when I would start pumping. So if it's 3 months, at 1 month, you could start pumping, you know? It's really hard for me to give very generalized advice because I've spent so many years customizing advice to specific diets and situations and bending or breaking some of the rules that I say.
Well, Kat, we appreciate all of your advice.
Thanks.
If you are thinking that you may have oversupply, again, see an internationally board certified lactation consultant. Please don't try to manage it on your own. And thank you for joining us. We hope you enjoyed this episode of the Postpartum Years podcast on oversupply, and we'll see you next time. Bye.